Hello, friends. I'll be giving a brief overview on this medication error. So, this is an important administrative topic which is useful for all the healthcare workers working in ICU environment. So, I gave this particular talk as part of a larger sort of a talk in Aurangabad on 13th April. So, the picture you see is of Daulatabad, which is present around 13 kilometers from Aurangabad. So this was the capital of Muhammad bin Tughlaq when he changed his place from Delhi to this place in 1327. So just a historical bit. So drug error. So what do we understand? What are the key components of drug error is what we need to learn. So if you look at this cartoon, it says that hospital medical errors, if you look at the bottom, kills 98,000 Americans each year. So this was a cartoon that came out in one of the blogs. So we are all bound by certain ethical principles. As you know, the ethical principles is autonomy, beneficence, malfeasance, and distributive justice. So malfeasance is do no harm. So whenever we do certain intervention in healthcare, we should always weigh the risk-benefit balance before a decision is exercised on doing any sort of an intervention to a patient. So we all understand that. And they looked at the data in Netherlands in 21 hospitals. They looked at the overall country data. There were 1.3 million admissions into the hospital per year. Amongst them, there were 6% of them who had unintentional harm in the hospital, which is iatrogenic or errors, so on and so forth. And in the hospital, if you take intensive care unit, this particular ecosystem has a maximum sort of a vulnerability quotient to have a lot of errors. Why that happens? Because the type of patients we get is very complex, very busy patients. There's a lot of things happening to the patient. Patient is on vasopressors, patient is on ventilator, patient is having dialysis, patient is connected to the monitor, they're getting a lot of life-saving medication. So there's a lot of processes involved in a patient who is very sick in ICU. So because there are so many processes involved in getting the patient better, there are more vulnerability for errors. And this was a important study for our reference, which was called SEE1 study, which is Sentinel Event Evaluation 1 study, where they looked at 205 ICUs and they found that the errors that happen in ICUs around 38.8 incidents per 100 patient days. So this was the landmark study in ICU, which tells that the number of incidents per 100 patient days is quite staggering and alarming at 38%. So it's very high. So this is where we need to put in our efforts to mitigate the errors. So when we talk about medication error, so there are two types of error. One is of omission, where you are meant to give certain drugs to an individual at certain time to reverse certain pathological process which has been omitted and that has led to perpetuation of certain symptoms, or it is commission, where a wrong drug is given. And both of these we understand causes harm to the patient. So when we talk about drug errors, there are five types of drug errors, out of which there are four wrongs and one missing. So the wrong is wrong medications, wrong dose, wrong route, and wrong time. So these are the four wrongs, and the last one is missing the drug, missing the administration of certain drugs. So these are the typical errors that tends to happen in any sort of a ecosystem. And most errors are found to happen in the routine care of the patients. 37% of the errors tend to happen in the routine standard care that is meant to be provided to the patient. It tends to happen. And most of these errors tend to happen when the workload for a nurse increases or when the patient nurse ratio tends to get skewed or gets disturbed. So that is when the errors tend to occur most commonly. So when the nurse patient ratio is skewed, so that is when these errors tend to happen. And the work burden is directly proportional to the drug errors, which means if the nurse or a doctor is overburdened with lot of work, then the patient gets more vulnerable for these errors. So if you just look at this cartoon, so this is a typical nurse in ICU who can be troubled with lot of things. They are dumped with lot of sort of responsibilities, and obviously when you have so much responsibility dumped on a nurse, they are very vulnerable. They crumble and succumb to doing a lot of errors. So this is a nice cartoon that came out in drug errors. So you look at the time, it's 3:15 a.m. So the nurse is come back from a break. and she was meant to administer an antibiotic because, as you see, it's a busy patient connected to a monitor, connected to a lot of infusion pumps. So she ends up giving the IV antibiotic in the extraventricular drain or the EVD drain that was in the head. So, which means this is a serious error that tends. It's just a cartoon representation of the context setting that tends to happen. A busy ICU with a busy patient connected to a lot of infusions, and time is 3:15 a.m., comes after a break, so she's fuzzy and administers the drug into the EVD drain. So these are all the established sort of errors that have been sort of referenced in the literature. So what are the contributing factors for errors? Obviously, I said patients in ICU are typically like this. They're connected to monitor, connected to ventilator, connected to a lot of infusion pumps. So there are a lot of things a nurse has to take care or pay attention to, and the vulnerability of committing an error tends to increase with such a busy patient. So, and errors directly proportional to the workload and the number of ICU beds. So, if there are a lot of ICU beds and staffing is not adequate, and when there is complexity of the patients or more, suppose if you have a busy ICU where two, three patients are on ECMO and there are two, three patients on dialysis, and you have a competent staff not necessarily maybe adequate to take care of these situations. So, they are at a risk of conducting a lot of errors, and lack of communication between the nursing personnel taking care of these complex situations also leads to the errors. Or if there is no sort of a teamwork that is put in place for effective functioning of the nursing, so if there is no effective team leader, that's why most ICUs now, for 6 nurses there'll be one team leader, or for 10 nurses there'll be one team leader who is meant to coordinate effective functioning or the process driven sort of a functioning of a nurses to mitigate the error, because team leader is meant to oversee. And this, in most of our hospitals in abroad, overseas, or even in Manipal hospital, we have team leader for at least 10 nurses who tends to oversee, handhold them, and try to assist them in effective functioning. And measures to reduce errors, have a checklist, because it's very important to have a checklist whilst administering drugs. Because in overseas, when I was in Australia, we always had any drug administration to be cross-checked by another nurse and signed. So any drug administration is signed by 2 nurses. One, the nurse who is at the bedside, and it is cross-verified and signed by the team leader. So this mitigates or minimizes the risk. And the design of infusion pumps. So how the infusion pumps are placed, whether they are labeled well, and some structure in the formatting of these infusion pumps also helps, and educating the nurses about the way these needs to be laid out also helps in mitigating the drug errors. And we'll talk a little bit on critical incident reporting system as a tool to look into the root cause analysis for such drug errors and take effective means to mitigate the drug errors. And we have critical incident reporting system in our hospital Manipal. So, and these are very valuable tools, and any hospital for that matter, with any NABH accreditations are mandated to have critical incident reporting system. This is a process to understand the sort of errors that tend to happen and go into root cause analysis and put in steps to avoid such errors. So that is the whole purpose. And making nurses aware of the risk of drug errors and screening for drug errors goes a long way in mitigating it. And if you look into the data, there is a more emphasis on sort of a teamwork in ICU, and it is shown 77% of all errors happen between the administration and the ordering phase. So when you order the drug, between the ordering and administration, 77% of drug errors happen, and 23% tended to happen before the administration, and 39% in other areas. So this is a quality benchmark. It's a process benchmark or a process indicator in ICU, and the standard or the benchmark errors that you can afford to have cannot be more than 5%. So that is the sort of, so you would best want it to be zero, but it cannot be zero. But your drug error should be less than 5%. If it is more than 5%, you have to put in serious steps to mitigate it, because you saw there per 100 patient days, when you look at the data, it was more than 30, so which was staggeringly high. So our intent is to reduce it to less than 5%. So we'll talk a bit of critical incident reporting system was first evaluated in 1940 by Flanagan. and put in place in US in 1978 by Cooper. So basically, the whole purpose of critical incident reporting system is to improve the safety for the patient by learning from the incident that has happened or the near misses of errors that would have happened. Basically, it's a learning exercise so that measures are put in place to mitigate the errors. And the definition of event or circumstances which mandates critical information is any intervention that has caused harm to the patient or could have led to the death of a patient or that could have perpetuated the suffering of the patient should be looked at as a critical incident, and that needs to be reported as critical incident reporting system. And there are steps for critical incident reporting system. This could be asked in your DRNB exam. So basically, it is collecting all the data that has led to the error. So it has to be independent and non-punitive, and gathering of the data and handling of this data is important. And the data that is collected, which has led to the drug errors, have to be analyzed. And we call it as data interrogation. And meaningful learning has to happen from the data that has been synthesized, and making a sense of the data that you have collected, which has led to the error, is usually an arduous and a lengthiest sort of a process. And so there can be the sort of a care management problems that mandate this sort of a data analysis is delay in the diagnosis or lack of monitoring that was meant to have happened has not happened, or pre-operative checkups that has not happened, inaccurate treatment that. So these are the data points that you would wish to collect in, we call it as CMP, which is clinical management problems, which are identified as problems are these where there has been delay in diagnosis, where there is no adequate monitoring that has happened, where pre-operative checkup has not, inaccurate treatment has happened, or there has been deviation from the protocol, or protocol has not been adhered to, or there has been inappropriate or inadequate handover or supervision. All these constitute the data points that are meant to collect to make analysis of the data and take necessary steps to prevent the to prevent the events that has led to the drug errors or medication errors. And one needs to ask these questions, which are defined in the literature as what, how, and why. WHW, what, how, and why has to be asked for all these uh, clinical medical problems that have risen in a patient. So one has to ask the question, write a possible solution, which should lead to the steps to put in place to mitigate this medication error. And there has to be a feedback. It is suggested that the feedback of critical incident reporting system should percolate from higher up, from the ICU director or the nursing director to way down to the front desk person. So it should percolate at all levels, even from hospital head to the nursing head, to the ICU head, to the ICU team, to the nurses, and even to the ICU secretary. So there, the feedback has to percolate so that everyone is aware of the steps that are put in place to mitigate the drug errors. So why there is a failure of critical incident reporting system in many places? There is failure because people are worried if they report certain error that they have performed, that there could be a punitive action. So people are worried about the punitive action that may be taken. That's why one does not report it. Although we anonymize the critical incident reporting system, but people are worried that there could be a punitive action. That's why not many report it. And people are worried about legal ramifications or legal sort of a punitive actions that they may be, that they may have to face. And people are worried about workplace discrimination that may happen, saying that this person sort of a error led to the death of a patient. That would lead to stigma or taboo. People are worried, and these are some of the reasons for failure of critical incident reporting system. And there is a deep entrenched belief in most of the healthcare personnel that only bad doctors make mistakes. So that I think that one should sort of dissociate from this sort of a belief, because somehow there is an innate sort of a belief system that good doctors don't make mistakes, only bad doctors. So we have to debunk this myth. And these are some of the reasons that are cited as some of the factors that lead to the failure of reporting all the incidents, and most of them are sort of brushed below the carpet. So this is something we have to educate the nurses or the doctors and tell them that incident reporting is mainly to improve the system, improve the processes, and put processes in place to mitigate the errors that may threaten the patient's outcome. So this is what we need to educate and put the process in an anonymized way, so that more the process could be made more robust and measures can be put in to make our work environment much safer. So that's all it's about. The medication errors, more of administrative sort of a lessons for all our ICU trainees. So thank you one and all. So you can submit your valuable work to Journal of Acute Care, and of course you can visit my website to rehear to this lecture. Thank you one and all.